the Wednesday morning rounds. I would like to introduce Dr. Elizabeth Chan to do a talk about on the future of TAVI care. So Dr. Chan completed her medical and cardiology training in UK, and she also did a master's in global health policy at the London School of Hygiene and Tropical Medicine, and she joined us in the interventional cardiology program. Thank you very much for doing the talk. Just a couple reminders. One, please submit your questions in the Q&A or the chat box if you are joining us online. And don't forget to sign the attendance sheet at the back of the room. We have a last-minute cancellation, unfortunately, and so next week there will be no morning rounds. Thank you. Thank you, Dr. Chan.
Good morning and welcome. For those of you who I've not met, my name's Lizzie. I'm one of the current IC2s. I, as Dr. Aiden has said, have a specialist interest in global health policy, having completed a master's at the London School of Hygiene and Tropical Medicine. This is surrounding health systems, infrastructure, and finance. It gave me an additional avenue and a different way of looking at the way we work every day. I also have training within TAVI, CTO, and intravascular imaging, as well as microvascular, granted here by the great team by the Interventional. So this may feel like a little bit of an odd objectives. It looks like it doesn't really link, but I'm hoping you to take you on the journey to see how we got to where we are today. Have a look at the pressures, the things we need to think about, the things outside of our regular sphere that I would like us to potentially consider day to day. But then also, how do we look forward, take all of this together and take the next step? So these are the kind of things that we'll get into. To start with, also, we'll go through a whole bunch of trials. Now, I'm really going to skim over some of these details. I have the slides and also the papers, so if people want to go into the details a little bit more, I'm more than happy to provide those. But the real purpose is not to look at the research in detail, but to see how it's expanded our sphere of influence. But to start with, where did TAVI begin? So TAVI began over decades ago with Alain Cribier, who's an interventional cardiologist from Rouen, France. Previously, the only option open to those with severe aortic stenosis was balloon valvuloplasty, and this was previous to having only open surgical aortic valvular repair. In 1985, Dr. Cribier decided, why can't we do something for them percutaneously? So in 1985, he offered a critically unwell 72-year-old female a balloon aortic valvuloplasty. So for those who aren't aware, that's simply just a ballooning across the valve to open up that valve area. She was actually able to then be discharged within the following week and resumed her normal life. He then published a case series of 3 patients who had undergone balloon aortic valvuloplasty in 1986 and suggested this as an alternative for those who were too high risk or too elderly potentially to undergo surgical aortic valve implantation. The problem with that, however, is that the valve continued to re-narrow. There was recoil of the valve, and they ended up at square one after potentially months to years, and the outcome was still the same. So the thought was, well, the surgeons sew in a ring, so why can't we create something that makes the valve stay open? And hence the first TAVI was developed. This was done after research in sheep, and they demonstrated that the durability of the valve was about 2.5 years. And they created this, what looks like a very rudimentary version of a valve. This was done for a last resort, extremely high risk 52-year-old male as the first in human in cardiogenic shock. He was the patient of nightmares that we get referred. So he had an LV of 14%, a previous lung cancer, severe peripheral artery disease. He previously had an aortic fem bypass, and he had bilateral pleural effusions, was in active shock with a mean gradient of 30. And so understandably, the surgeon said, no, thank you very much. And he was the first candidate for the first in human TAVI. It was done extremely differently to how we do things today. And it was an antegrade transeptal approach from the right femoral vein, with a 24 French sheath. The valve at that point was only 21 to 23 frame, and it was used with bovine pericardial leaflets, and it took his mean gradient from 30 to 13. Unfortunately, he died of non-cardiac causes, but he didn't have any further episodes of heart failure during his admission, but he'd never made it out of hospital. You can see this acted as a platform for the ideas. And over the years, it was taken up by two main companies, that be Medtronic with the core valve and Edwards for the Cribier-Edwards valve. And these were the first two main valves designed. There were only limited sizes, so 23 and 26, but you can see the size of the delivery sheath is really quite large, 22 and 24 French sheath, and then also 26 and 29 valves. These were using bovine but also porcine pericardial valves, and the core valve is different as it's a nitinol titanium alloy. Here you can see then the idea of TAVI really started to take off. From the over the last decade or so, we've had multiple research projects demonstrating efficacy, of which we're going to skim through some of them today. The idea about showing you how quickly this has developed is also to think about how the equipment has developed, how the valves themselves are developed, but also look at the number of patients that all of a sudden become eligible as these projects come about. So the very first was partner 1 with a cohort B. This was standard of care, so including balloon aortic valvuloplasty for those who are non-surgical candidates against TF-TAVI. The primary endpoint was end cause of death, and this demonstrated that there was a superiority for TAVI against medical therapy alone or balloon aortic valvuloplasty. This really started to be the working platform, especially for the FDA and the Canadian trials, to be able to approve this for inoperable high-risk TAVI patients. Cohort B, however, did demonstrate that with the TAVI, and things we're starting to think about, but that there was an increased risk of stroke in comparison, major bleeding, as you can imagine, with the very big tubes, as well as major vascular complications. Cohort A was run side by side. It was a different cohort. This was the TAVR versus SAVR for high-risk candidates. Now, these patients had an average STS of more than 10%, or at least 15% risk of death within the first 30 days of the procedure. Again, it was pretty even. I haven't put all of the kind of baseline characteristics, but very evenly matched across the board. And again, all-cause mortality at 1 year is the primary endpoint. Importantly, and with majority of all of these trials, excluded from these patients cohorts are bicuspid patients, those with a reduced LV function, so generally under 30 but also under 20%, those with severe MR, severe AR, complex coronary disease, as well as recent heart attack, acute MI, stroke or TIA, and severe kidney function. So those patients are always going to sit outside of this sphere of pointing us exactly where we should go. But again, TAVR was demonstrated as non-inferior, and so TAVR started to be offered as an alternative for high-risk surgical patients. Then we have our Edwards, but they wanted to look at a different valve. So this is the core valve Medtronic pivotal trial. By this point, because of the partner 1 with the cohort B, it was no longer ethical to randomize the core valve to medical therapy, including bicuspid aortic valve. And so they also did the high-risk centers, so again, core valve against high-risk SAVR, and this again demonstrated that it was non-inferior. So now we have two different valvular platforms, for which I'll go into why we may want to consider this. Again, at 30 days, there were high risk of stroke with this, but it also then acted as FDA approval for the core valve for inoperable patients. So whilst it's great that it was for high risk, they then moved to intermediate risk. Again, it was non-inferior. This was starting to use the newer generation of valves. So we're then moving into thinner stent frames. And instead of just having a 23 and a 26 valve, we now have a 29 valve. The delivery profile of the catheter was also starting to move to a smaller French. And these patients were sitting in around a 4 to 8% STS score. This again was using, and I know I'm really whizzing through some of the charts here, was used for intermediate SAVR. And then again, partner 3, we're starting to come to now really a lot of patients being eligible for us. But what's important about this slide is the baseline characteristics. We all know that study patients are very specific, chosen, and they fit within a very narrow window. And so these are using a 3rd generation SAPIEN valve, so that's an Edwards valve for non-inferiority, okay? This was also done across the US, Canada, Australia, and started to open the sphere of influence. So using New Zealand, Australia, and Japan. So slightly different operating, different ways of being trained. However, the patient cohort is still the same. Again, we're still not including bicuspid valves, and these patients are really quite low STS. So they're less than 4, with an average STS score was 1.8. 24% of the surgeries were performed minimally invasively, but 80% of the valves that were placed from a TAVR point of view were greater than a 23. and I'll get to why that's important later. This demonstrated that TAVI was superior to surgery at a 1-year composite endpoint, but also subgroup analyses showed that there was lower rates of atrial fibrillation at 30 days, shorter index hospital stays, and faster recovery, which, considering our patients are on average 73 years old, and we'll get into the health systems later, is extremely important. This trial, most recently done by a Canadian colleague, Early TAVA, is also going to change our outlook. This is a prospective, multi-center, randomized control trial for asymptomatic aortic stenosis. Previously, this would only have been clinical surveillance, but this randomized 1-to-1 TAVR versus clinical surveillance. Again, these are very specific when we need to be thinking about who this applies to. There's a mean age of 75, and again, a mean STS of 1.8 with very low surgical risk. The idea and the way the trial was designed was superiority for the intention to treat with minimum follow-up and a composite primary endpoint. With this, patients were demonstrated to it was superior for TAVI over clinical surveillance. And here the difference is that the study is very limited just to primary TF TAVI, so transfemoral only using Edwards valve, and the level of clinical surveillance which was conducted by the study was very, very rigorous, which may not always be representative to that outside of a clinical trial. But thinking about this, regardless of the outcome, on average, these patients then converted to symptomatic severe aortic stenosis within a mean of 11.1 months. So regardless of whether these patients at the time of being randomized were going to come our way, they're going to come our way at some point. So thinking about all of these patients, where are they going to end up? They're going to end up with our service potentially. So whilst that was a real whistle-stop tour, there are robust trials. We know that the devices work extremely well, and the device development has been expedited, but also come such a long way in a short period of time. So with all this evidence and all this data, where does this leave us today? Whilst research helps us answer these questions and support our day-to-day clinical decision-making, there is an impact in research that the research is not always applicable and can't always be applied to everyday working life. As we are aware, many patients fall outside of the study cohort, as we have said, and so we need to use our data available, also our clinical judgment as clinicians every day. This combination brings us to our everyday clinical care and our TAVI service here at the Heart Institute. The TAVI program was developed in 2007 as an early adopter of technology, reaching nearly 20 years of implanter experience here. At that time, the program was funded to do only 100 TAVIs, and our operators here have assisted in introducing TAVI programs within the province, but also nationally, and have trained dozens of operators now that work across Canada as well as worldwide. So now I'd like to transition to look at the local data and what we currently are able to do here as a TAVI program here in Ottawa. We currently have 4 TAVI platforms. That would be Edwards Sapien 3, and you can see the valve size and the real change in size of the delivery platform here. Medtronic Evolute, FX, and also FX Plus, which is the newer evolution here with a coronary reaccess redesigned. An Abbott Navitor valve, which is currently undergoing one of our trials here with Envision with Dr. Abdurazik, and also the Jenna valve, which is the Trilogy, which is the only valve currently licensed and designed purely for aortic regurgitation. You can see here they're all slightly different designs. The Edwards valve is the only balloon expandable, whilst the others are self-expanding. And you have an intra-annular for 2 valves and supra-annular for the other 2, all of which are considerations done at the time of TAVI planning about which valve would be more important. Sorry, not more important, but more suitable for the patient. So what are we doing here? So we're completing on average over 400 cases a year. You can see over the years, and apologies for some of the data missing, but we're having increasingly number of referrals, as well as a reduce in outpatient wait, but we're also sending increasing number potentially for surgery. We do decline patients for multiple reasons, but we also do ask the referring physician to follow them on occasion. But you can see here that this is creating a potential bottleneck. Okay, and along with this, whilst the cases may not be done by our TAVI program, it's not that we're reducing the burden of cases or the workload, we're just shifting that into another sector of the Heart Institute. The average age of our patient is 78, with a strong predominance as per demographic demonstrations is normally male. We do offer those and a service to Quebec. On the other side is that Hull and Gatineau do not offer TAVI, and so we offer the service here for them. Otherwise, patients are then sent to Montreal. And we do inpatient and outpatient. However, the predominance of the inpatient, the incidence of the inpatient requirement is coming up, which is something that we do need to look at. We are a predominantly transfemoral center, and I think and the bosses will tell me if I'm wrong, are a pretty aggressive femoral center. So we will normally do things, we can do things like shockwave, we'll do joint cases with vascular, whereas other centers may convert to an alternate access much more easily. Alternate access, from my experience, will be generally going to transapical or transcarotid, and different centers have taken different approaches about how they do their alternate access days, whether they do a full transcarotid day, a full transapical day, or just fit them in as we do and do one case alternate access and the rest transfemoral. However, whilst we do high-risk hostile femorals, we need to consider the burden of care with regards to the difference between transfemoral and alternate access, but also over the years, as we would expect as patients are getting older and more valves are needed and redo procedures, we're getting more and more complex patients such as valve-in-valve patients. You can see here that our average length of stay for outpatients with transfemoral is also increasing, and the pre-TAVI wait for someone who's referred as an inpatient is on average 9 days, all of which this time is spent in the hospital, all of which has ongoing effects. So why does any of this matter? Here is where I'd like to change gear, take a step back outside of the Heart Institute, outside of Canada. Why does this matter to us? We are one of 11 TAVI centres here in Ontario, and we're one of the highest volume centres also across in Canada. So you can compare our data across province, but also nationally. The trends from our Heart Institute TAVI data are important to put into global context, considering all of this, to look forward for service improvement, but also care provision, but also the financing, the structuring, the drivers of services. I'm using the TAVI service here as an example from personal experience, but I hope and I'm sure that colleagues across other subspecialties and specialties can see how this is also important to theirs and can draw comparisons and parallels to their services also. The trends are important because whilst it's often easy to overlook current roadblocks, identify frustrations and think that there's an easy fix just in this one corner for us, everything exists within a bigger system and have knock-on effects that may or may not be anticipated or be able to be reversed or put into place. That's why taking a step back, looking at the wider picture and trends about how our world and everyday working sits within a sphere is important. This is why I felt that it was important and decided that from our day-to-day, regardless of how this is shaped, we need to look at the financing, the policies, and how these decisions are generally far removed from your average healthcare worker. I can attest, and I'm sure all of you have, you've been on the floor, you're working, and something has changed, a policy has changed, something has shifted. You don't always think it makes sense from where you're standing, but where the decision is made is a long way and many probably echelons up from where you're standing. So because of this, I made the decision to undertake my master's to begin to understand the healthcare system within a wider world. I believe that these decisions will filter down, but you need to understand, use the language and understand the sphere of influence that these people work within to have a seat at the table to be able to help influence your own life and work within these scenarios. So this incorporates policy, law, infrastructure, financing, and many other facets that sit within this. And how is this going to be important? The challenge that we know that we are seeing, and whilst not limited to this list, these are the main competing globally concerns that I would argue that no single health system, regardless of structure, financing, or operating style, is immune from. That includes healthcare access, increasing waiting times, resource constraints, increasing treatment costs, infrastructure limitations, aging population, and increasingly complex patient demographic. These challenges are mapped and collected by an infrastructure called the OECD. The OECD are Organization Economic Cooperation and Development, which is a global partnership of 38 countries that come together to collaborate public policy whilst collecting social, economic, and environmental data. This is an attempt to strengthen political policy and also public policy, whilst working closely with the policymakers, stakeholders, and citizens for evidence-based standards. These are measured using these core indexes that you can see here, but there are other indexes that are measured also. The idea is not to identify which country is performing best, or indeed the perfect system, which I believe there is not, or we have not created one, but instead to identify relative strengths and weaknesses, and thereby identify areas for policy and priority concerns. So how does Canada fare using this cross-country comparison? It gives us an idea of strength and weakness and where we may be able to change. Just for reference, for those who have not, or have this is an introduction to the OECD here, you can see here the countries that are involved within the OECD that contribute to the data. And it's important to note that there are different cultural attitudes, geopolitical pressures, geographical changes, climate changes, family structure, GDP, social structure. So all of these countries work within a different way and can give you a different view of way of working with things. Now, these graphs I found a little bit complicated when I was first looking at them. So here you have your OECD dot here, which is the OECD average of all the 38 countries. You have your worst performing here, your best performing here, and Canada is the blue circle here. So Canada in general performs extremely well and better than average, but to 8 out of 10 OECD key indicators as a measure for health status and risk factors for health. And I'm sure these things come as no surprise for everybody that works every day, that there are some areas, however, that Canada struggles with. And having worked within another medical sphere, so the UK, that equally struggles with many of these things, we know that it's very difficult to combat. So whilst 98% of the population here is covered for core medical services, only 50% are satisfied with the available quality of healthcare, with 70% of their financial coverage covered, which is lower than the OECD average of 75%. The general driver for this is paying for medicines. Health systems resources indicators such as practicing nurses and pharmacists are above average for the OECD indicators. However, despite above average per capita and per GDP resource spending, there's still significant limitations. For example, CT, MRI, PET, hospital beds, and physicians, all of which I can imagine you think, yeah, I come up against that. So you can see here how the global challenges such as wait times, constricted resources, and infrastructure limitations are reflected accurately within the daily Canadian healthcare system. So with this, you can see also how the wait times are demonstrated. So whilst you get the brunt of it when you see them in outpatients clinic, asking, well, you've told me I can have this procedure, how long is it going to take? By the time that the patient gets to you, they've already potentially waited a significant amount of time, not only to then see their GP to get them a referral, but then to get a referral on to see their specialist. And then once we get here, we're rushing them out the door because we need the bed for somebody else. Running the hospital at 91% infrastructure is like constantly running a marathon. You're constantly stressed. It's constantly difficult for everybody. Whereas other countries somehow, and to be honest, I've never been to hospital in Greece, so I can't comment, supposedly have a 52% hospital bed occupancy, which must be like walking through and half the place is empty. So with this, we break down these indicators to look at where the stresses are. The stresses are here, that's fine, we can acknowledge that. We're still surviving every day, we've got to provide care. But how do we make these improvements? How do we change these things and use the resources currently that we have whilst looking forward to alter these? Can we change it? Can we change the resource allocation? And that's where we need to look at the money. So health expenditure per provider looks at where the money is spent from the healthcare budget. So here it shows that you can see that the hospitals receive 27%, which is below the OECD average of 39%. Long-term care facilities are next, and ambulatory providers are people such as general practitioners, specialist practice groups, dental and home health, whereas retail counts for things like pharmacies. Other includes things like laboratories, patient transport, healthcare administration, as well as public and prevention agencies. These are different across all of the different countries for different priorities and expenditures, but also shows you where the potential efficiencies could be created given where the money is spent. It also reflects local pressures and again, who's at the top driving the policy. So currently, the total healthcare budget is $399 billion for 2025. That's roughly $9,626 per Canadian, which is 12.7% of the GDP. However, whilst it may be great and look like a fantastic slide here, a plus 7.4%, 6.1, 4.2, when you look at the population size and actually then do that for real growth, you've got minus 1.4% growth rate for real per capita health spending per Canadian. This, whilst is an average of 9,626 per Canadian, you have to remember that it's a lot more expensive to provide healthcare to someone in Nunavut than it is here in Ottawa. And so that the federal budget, whilst allocated, is also different and then evened out per people. How far is this really going to go? There's a population of roughly 41.6 million with an average life expectancy of 81.7 years. The Ontario population alone is 16.1 million with a growth rate of 0.9% over the last year. Now, the average life expectancy is important. This has increased a lot and is also different as per the population. But this is projected to, it's important as over 18.9% of the population is over the age of 65 currently. This is projected to reach 24% by 2030. And whilst that only accounts for roughly 1/5 of the population, those over the age of 65 account for 44% of the expenditure of a healthcare budget. The fertility rate is also important. This has reached its lowest recorded ever in 2024, with only 1.25 children per woman. Under the barrier of 1.3 children per woman, the country is deemed as ultra-low fertility. This is alongside countries such as Switzerland at 1.29, Italy 1.18, and Singapore at 0.97. This leads to a shrinking tax base to fund the medical care, with a shrinking pool of medical workers, whilst bearing the brunt of an aging population and the financial struggles that go with that. Immigration also brings its own challenges. Whilst being a strong proponent for contributing to the workforce, immigration also adds demand, especially in urban areas, unique healthcare challenges such as need for translation and culturally tailored care, as well as combating issues with access. There has also been an increase in prevalence of obesity from 25 to 33%, with the largest increase seen in ages 18 to 39, male and female, but also in children. There's roughly 10% of the population is diabetic, with a further 6% are pre-diabetic. That equates to 4 million Canadians. By 2030, that's estimated to be 14 million. All of these factors affect the healthcare, the budget, the spending, the everyday work throughout each province and each different. So how do these all relate back to aortic stenosis? Because I know that you feel we've come a long way since then. Oh, let's not skip slides. So with this, all of this is showing increasing resources, increasing age of population with resource limited. So how are we going to use our money properly? Are these therapies that we are offering at really expensive valves even worth it? And how do we adjust that? The prevalence of aortic stenosis for those over the age of 75 is roughly 3.4%, but over the age of 65 is 2.2%. And we spoke about the aging population. So whilst it's roughly 2.9 million in 2025, it's going to be 3.3 million over the age of 65 in 2046. 2046 might sound a long way off. I know that unfortunately, or fortunately, I will still be definitely working at this time, okay? So it's not a future problem. This is a now problem that we need to be thinking about, and how are we going to cope with this? Whilst that only roughly equivalent, it comes down to 50 TAVI patients additional per year, how are we going to do that? We're already working out as flat out as we possibly can with all the pressures that you have now seen globally, but also nationally, with restricted funding, proportionally less money, proportionally fewer resources. So is the math really mathing? Doesn't feel like it when you look at these numbers. This is where cost-effective analysis comes into play. And with the most recent extensive analysis completed in 2020, which looked back at the low-risk candidates, which, as we said previously, were not a candidate, but now everybody is able to have a TAVI, where do we come to? So a balloon expandable TAVI, so an Edwards TAVI, costs roughly $26,000. A self-expanding TAVI costs roughly $25,000, but a surgical valve only costs $6,000. So you're saying to me, well, how on earth does that make sense? Cost-effect analysis includes many elements. It includes both the valve, the initial procedure, complications, and these are all put into a Markov model to use from the perspective of the Canadian payer. So for Ontario, and this is how this model was done, was the Ministry of Health, so that's who's paying. The data was taken from the meta-analyses and used the most recent costing, as well as the Partner 3 and Evolute LRT trials as the basis for the federal approval to increase the budget, which was estimated at an increase of roughly $5 to $8 million to be able to cope with introducing TAVI to the low-risk population. A Markov model is a mathematical model that generates future states dependent on the current state. This is widely used within healthcare economics to simulate scenarios such as disease progression, but also spending, for example, as here. The drawback is that it doesn't have memory, the model, and you often need to be able to put in input additional data as you go along, but this also does enable some forecasting. The ISA that you see here is the most important element. So an ISO is an incremental cost effectiveness ratio and is the health economic statistics of comparing two medical interventions against each other, calculated as the difference in cost divided by the difference in effect. It represents the additional cost per extra unit of benefit. So in this case, and in most cases, it's measured using QALY, so quality adjusted life years. It is used to help determine if a treatment offers enough clinical benefit to justify the cost. So here, this is TAVI, both balloon expandable and self-expandable versus SAVR. And so is this a useful use of our money, but also a resource allocation? Generally and worldwide, the willingness to pay threshold, which tells us about whether it is worth it or not, is about $50,000 per QALY. So you can see that the balloon expandable TAVI clearly meets that, and just above that is the self-expanding TAVI. However, both were then authorized for use within the Canadian system, given that not all are suitable for Edwards TAVI, but also the future cost with the Markov model demonstrated that these will reduce with time. And so you can see here that the drivers here are the length of stay. Our patients stay for possibly 1, if not 2 days generally, with lower complication risks with TAVI, and also the length of procedure. We do have to consider, however, that the valve longevity. This was done with the study population, as we spoke about. Mean age of 73, first time they've ever had a valve. And then we need to consider, as we give these valves to younger and younger populations, these numbers are not going to be as applicable for redo procedures, but also the long-term data for the valves. So with all these numbers, limits, and what it feels like a slightly bleak picture that I've put together, how do we bring this all together to make a cohesive, efficient, and functional service? We already cater to a large population providing high volume care, but can we do anything better? Can we be more efficient? Can we change and drive different outcomes and potentially improve finances? So we do know, and as we saw through the data, that we are currently seeing an increasing number of referrals, an increasing proportion of inpatient cases, increasing length of stay for both inpatient and outpatient transfemoral TAVIs, which should be the quickest and easiest to discharge, prolonged inpatient waits for TAVI, but also increasing proportion of complex cases. Anecdotally, also in clinic, we're seeing increasingly frail patients that also require more investigations done at the time of clinic, and all of these things delay and add to the burden of care. So if patients are increasingly frail, they're slower to get up, they're harder to discharge, and that I think reflects some of the difficulties of getting people out and the increasing length of stay. So these trends are in keeping with the global pressures that we've discussed and reviewed, but while also being affected and being some of the drivers for some of the issues. So we need to put all of this together to create and also reduce some of the downstream and upstream concerns. So what are we doing here at the Heart Institute to help with this? Currently, we have just started doing our same-day discharge. So these are patients who will come in on the day. They will not technically be an inpatient. They go home same day, whether that be roughly 4 or 5 p.m. We're currently limited to roughly 1 or 2 out of the 5 patients that we do twice a week, on the 2 list that we do twice a week. There are clear geographical concerns. And when you think about the catchment area that the Heart Institute caters for, it is very hard for all of them to be able to be within a safe driving distance of acute medical care. So a lot of our patients already fall within outside of the bounds of being able to be within the same day discharge. If we have inpatients, we also struggle to then put lots of same day discharges as they need to be prioritized and done potentially earlier in the day. Also streamlining review at left heart cath. So patients who need an angiogram are coming in and we're doing the TAVI consult at the same time. So instead of coming in for your angiogram, then coming in for a consult as outpatients, we are doing all of that all in one go. Whilst this works for some patients, it doesn't work with others, and it can be a little bit hit and miss for some people. So we do end up seeing some people often via phone, but it does save both the patient and also potentially another outpatient appointment. We're also in the process with our wonderful TAVI team here, developing a nurse-led follow-up clinic. So at the moment, we also do a telephone follow at 1 month with the results of their repeat echocardiogram. This takes up maybe 2.5 hours of our clinic day on a Wednesday, and we're going to see whether we can transfer this onto a nurse-led service, which is protocolized, providing that there are certain parameters that the patient meets. This will free up a 2.5-hour potentials for additional consults for us to be able to see. This will streamline the outpatient wait, but also make sure that we're moving things fast along. The preclinical coordination is key. And for those of you who have not met the wonderful Liz, and we've also just introduced Tricia to our team here, these are our TAVI queens. They know all of our patients, not only by name, but by problem. They speak to them via the phone. Without this enabling to navigate patients through this really tricky time from referral to test and what is this? Why am I coming for this I thought I was here for the procedure. These ladies are critical, and the TAVI service wouldn't be able to be what it is today without them. We've also taken the approach of using our data collection and turning this and also doing research programs. So at the moment, we're doing a retrospective analysis currently or starting to for all of our inpatient cases. We're going to see why are we doing so many inpatient cases? Did this really need to be done as an inpatient so we can change our current practice? This will be beneficial not only to free up beds, but the cost will be less, as you can imagine. If we don't need to do it as an inpatient, we absolutely shouldn't, because the cost is roughly 5 times higher. But also, it's not good for patients. They're sat around in their beds, not moving for days on days, and then we do a procedure for them. We could be doing this better, potentially. We are also included in the trial with Envisions with Dr. Abdulrazik currently, and this is a head-to-head with Navitor, so we're trialing new platforms. But potentially, and the way that other hospitals are looking at things, is other ways of going about things. These are all very much different ways of looking at things, remembering that all of these would need financial investment, would be potential big structural changes, and it's all a little bit of not a pipe dream, but different ways of looking at things, and maybe far off, but things to think about. One thing to look at is process mapping. My previous centre did not routinely do angiograms for anybody over the age of 80, regardless of whether they could or could not see the coronaries. It was felt that if they had true severe aortic stenosis with the symptoms, to do the TAVI first and then to reevaluate after. That would cut one medical test, as well as streamline from referral to procedure. We don't do angiograms on here by any on every single patient by any stretch of the imagination, but it's potentially one way of just changing the patient flow. Operating capacity is extremely difficult. We currently operate in OR6 twice a week, and it is also a very highly specialized team that you need to be able to do this. So both from a nursing and physician point of view. We have an interventional cardiologist and a surgeon present, so you would need effectively more of both, if that makes sense. But where are you going to get an additional operating theatre from? We do roughly 5 cases a day, but we are limited from an infrastructure point of view of when we can put the last case on the table. So it's not inconceivable that if the patients are difficult, where there is an unforeseen complication or something doesn't go quite to plan, unfortunately, we are in the habit of having to cancel 1, maybe 2 cases. And these patients have traveled far, they're starved, they're a bit grumpy, they really wanted their procedure. It's not easy, especially not for our wonderful TAVI team, who often receive the brunt of it via the phone. And it's something we don't take lightly, and we also really don't like doing. So if we could potentially increase our operating capacity, one way of looking at things would be for high-risk patients with no options for surgical bailout. For example, if there is a complication, we would open the chest to convert to open surgery. Could we potentially use the cath labs downstairs? Again, cath lab time and space is limited, but one way of looking at things, and the ways that other hospitals have looked at things from what I can see, is that if there is no chance that they would convert to surgery, you don't need the OR theatre. So could you move this and put this in a different space? This is difficult from a training point of view and a resource point of view, but also people are really used to what you're used to. We're used to being in OR6, we have everything. But it's one option to look at things. But then again, you're pushing one demand onto a different element of your system and creating a different dynamic downstairs and increased pressures. There's also transitional care programs, and this is something that was looked at in Germany. They created early support discharge teams, but also specifically were to help them get home quickly, but also to keep them at home. And this was reducing the readmissions. So for your older, frailer patients that feel like it's quite a lot to get up and about, who get a bit nervous, who don't feel quite right, who then call and end up in the ER and get readmitted, not for anything particular, but maybe we just rush them out a little bit quickly. That support of getting them home, all in one piece, reassurance, all of those things, and then keeping them at home would really reduce pressures. There is also fast track protocols for those who are low risk patients. In some hospitals, they've developed specialist nurse practitioners who will see and be triaged via a kind of green light or red light system, one that can be seen by the nurse during at referral, one that may need to be seen by a physician also. But then at the time of the preoperative anesthetic chart, the TAVI team, if they haven't met a doctor at referral, goes and sees them and says hello, make sure that there aren't any other issues that could be seen. But they're all completely discussed at the heart team review or our TAVI rounds, so they have had medical input. This would streamline things and free up the doctors to be able to do other things. There's also, and again in Germany, who's been a real driver of adoption of TAVI and driving of care in Europe, heart valve units and specialist teams. The heart valve unit is a specialist unit purely for TAVI, but also then starting to expand into the structural space. This is where the pre-admission, the pre-procedure, and then they go post-procedure. Their nurses trained specifically in wide bore access, also getting them up and about. And this is open kind of, not probably about 18 hours of the day, and enables you to then do the same day discharge potentially for your very last patient. So regardless of their needs, we're trying to keep these patients separate and get them with specialist care. At the moment, our patients go to reference. The idea will be for our same day discharges that they will go back to our day unit, so they're never technically admitted, which is a similar concept for that. But the pressures on day unit are different. They are not used to currently looking after arterial wide bore access post-procedure. Those patients generally go to CC or reference. So it takes specialist training, investment, and to be able to do this. And so whilst all of that seemed a little bit of a topsy-turvy whirlwind of TAVI, I hope you can see, although these things do it for me, and they may not do it for other people, these are the kind of things that I find interesting. And I hope that whilst these principles I have applied to TAVI today, you can see within your specialty or subspecialty and the pressures that we see here today. So thank you so much for listening. And I hope that wasn't too chaotic, and happy to take any questions, debate, or discussion.
Thank you very much. That was excellent, fantastic talk.
Thanks. That's it's wonderful to see the program. It's grown, and I love the future potentials that you mentioned. So one question I had for you, a lot of the decision making about policy as well as where to put the resources comes down to the data that's available.
Yes.
One of the quality of life funds that you were showing, 27,000 versus 59,000 for self-expanding versus the balloon one. Assuming the data is accurate, how do you explain the massive difference between the two in terms of quality of life adjustments, pricing?
The difference was taken, or the data is for the balloon expander was taken from partner 3, and the self-expanding is taken from Evolute LRT. The data was then compared to one another with the financing that they have, and it was felt there was a slightly higher incidence of stroke within the self-expanding, and that was generally, they also had a slightly longer stay for their study. On average, I think it was, instead of being 2.3 days, it was about 4-point-something days. And in the centers that they were doing it, they also did an ICU stay and then a ward stay. So their costs were more from a length of stay and complications, not necessarily because the valve platform is a similar cost.
So theoretically, the price for our center would be similar, assuming our operators are fantastic and they can
Correct. Yeah.
Great rounds, Lizzie. Thank you so much for taking a health systems lens. Quite an interesting question for those that have practiced at different centers where they do TAVI. TAVI is an outpatient procedure, and that might seem like revelatory to some of the audience here, but we have a 30% inpatient TAVI rate. Do you think that's a function of our low threshold to admit patients for TAVI, or is it playing catch up to a population that has been underserved and has progressed to the point of needing inpatient admission? Yeah, but great presentation.
Yeah. I think it's a combination of both, if I'm honest. Some patients are have never been seen a doctor before. They come in, they're really sick. You know, when you think about the geographical challenges and the healthcare structure and access, that's not inconceivable that no one has seen a doctor for 10 to 15 years. No one's listened to their chest, and they end up in a real heap. I think that's completely reasonable that these patients then, given the extremes that they're in, we do an inpatient TAVI. There is also, I would argue, a subset of patients that once we've had the conversations with them in clinic, they really freak out, and then they're calling, they present themselves to the ER, and probably out of the goodness of our own hearts, we do the patient as an inpatient procedure. Do we really need to if we looked at it? Probably not. And so that's where the data that we're collecting with Dr. Alatassi and Dr. Labanaz will be able to help with that. With regards to that, I also think that severe aortic stenosis is a scary diagnosis. People do drop down dead. And so when we are caring for them, or when people see extremely high gradients, understandably, people want to admit these people to hospital. It's different for the TAVI team. We deal with these patients all day, every day. So we have a level of comfort that I think some people, understandably, whether that's inside or outside of cardiology, don't have. What I would say to that is come and talk to us, talk us through the case, ask us, do you think this patient really needs to be done as an inpatient? And we'll see what we can do. Whilst things are limited, we may be able to, if needs to be, send them home and get them done and bumped up the list from a clinical perspective. The first patient, or the first thing that a patient always asks me in clinic is, well, when can you do this now? That sounds great. Come on, get to the real money. Tell me when I can have my procedure. And I always say to patients, we do this on a clinical needs basis. Generally, patients, as you say, can be done as an outpatient. They don't need to be done as an outpatient. So a lot of it is reassurance, but also us becoming more comfortable that we're going to see more of these patients have more issues. And so we need to be comfortable with sending them with safety netting.
Thank you. Very interesting presentation. When you want to make system changes, you need to have some investment upfront, I guess. How do you get convincing data to convince the payers that it's cost effective?
Yeah, that's really difficult. And I think that comes down to us as clinicians. All of these patients that come through our doors should be inputted into our systems in some way. Whilst the pressures of everyday life often mean that we either don't recruit patients to studies or maybe don't input this, we now have systems, for example, Epic and AI, that can help us put all of this together. We can use big data to be able to do this. So we need to accurately record, and then also be able to make sure that the people interpreting this data are medical. They're not just policymakers who have never worked on a hospital floor, and we use this data accurately, because whilst one person can sell the data in one way, we all know that everybody has 3 different ways of looking at the data.
And you have a big part that you don't capture, is that before they reach out to the Heart Institute.
Pardon?
There is a big part that we don't capture
Absolutely.
is before reaching the hospital.
Yeah.
Waiting time for echo, for diagnostic, seeing a cardiologist, being referred, all this time is not captured in Epic.
Yeah. I completely agree. And an infrastructure change for data collection and everybody using the same system from an electronic perspective would be fantastic, because the number of people that we either have to redo the echoes from an outside center, we don't have the access to this or that investigation, is time and money that we didn't need to spend. And then also is a barrier for patients and extremely frustrating for them when they're like, well, I've already had this 3 months ago. Why am I doing it again? So I completely agree. If there is a way from a policy or an healthcare infrastructure point of view, that, for example, the fact that the Montfort, ourselves and the Queensway all work on different systems, the time and the energy spent to collect all of this information could be much more straightforward and easy, all of which would save time, save money, but the upfront cost and the financial investment to be able to do that would be massive. Oh, sorry.
Dr. Lance, you managed to unmute yourself.
I need to do something.
Yeah, no, I think they just.
Can you hear me?
Oh, yes,
Yes.
we can hear you.
Yes. So excellent presentation. Really love the perspective. Still being patient centered, and but looking at the health system impact on quality of life years and so on. And I do agree with always trying to look at process mapping and how we can improve and create efficiencies. And you know, I like the idea of trying to move more patients as outpatients. I'll make a general comment that one of the barriers we have, one of the system barriers, is that in fact in the province, healthcare is really in trouble. 80% of the hospitals project deficits for the next year. The Institute's in a unique position. We're independent in the sense that we can focus on cardiac care, and the province is looking to us for leadership. So I think what you're presenting is an opportunity for us to lead and by example. One of the problems, though, is that although all of us, and I'm sure everybody in the room, want to enhance people's quality of life, it's why, and prolong life and alleviate suffering, from the ministry's perspective, that's not necessarily a bottom line issue. They may listen to that, but unless we can actually save money, it becomes harder and harder to implement things. So this is why I think the process review and things like this, so as we bring on new technologies, that we are actually exploring different ways of doing things that can actually be cost neutral or save money, in addition to looking at the outcomes. And I'll just make another point, is that two things you commented about Montfort and Queensway. Within the next couple of years, they'll both be on Epic, and almost all, except for one hospital, actually maybe two hospitals in the entire region, will all be on Epic, which is going to transform our ability to share information. And we're now looking at ways that we can actually take a leadership role in centralizing referrals to capture that information that you talked about, in terms of how long does it take to get a referral, what's the most timely way to get that, et cetera, et cetera. So really, really great talk. I definitely think we need to always be looking at our processes. And while we have always putting the patients first, alleviating suffering, prolong life, that's what we are about. We still need to be stewards of the resources, and we need to find, and the physicians, like you said, are the knowledge. There's so much knowledge and understanding of how things get done. We need the physician's knowledge and understanding to help solve those problems as well. So thanks again for a great talk.
Thanks, Dr. Bean. I completely agree, and that was part of the driver for the reason that I did the master's. A lot of these decisions, as you say, policy, all comes down to the finances, are driven from people who are not physicians, who don't have the same goals, ideas, and plans that we do, and don't do the work that we do day to day. And so it can feel as though we have these decisions dictated to us. However, if we enter their world, if we use the language, if we understand where they're coming from, we can bridge that gap. And as you say, become the leaders that can then really create a cohesive health system where the decisions are made together with physicians, rather than sometimes feeling as though they're made outside of and without the inclusion of our input and with our knowledge and drivers. So I completely agree. Thank you.
So
Thank you.
Lizzie, a fantastic presentation. Really great work framing the increase in needs for the TAVI program within the greater picture of the entire healthcare system. So really very, very helpful. Very interesting discussing potential solutions as well. And I wanted to make two comments about those potential solutions in particular. Number one, we're expecting over about 50 extra referrals per year. Is that so? That roughly.
Got it. Just basically divided by the 11 Ontario centres, which I know is not accurate because we do more than other people. So it was just a rough, so it's more likely to be more than that.
Got it. So anyway, so over the next 10 years, we can see almost a doubling essentially of our volumes per year. So that's well, we should really be taking that into account into our planning long term. You spoke about potentially doing TAVIs in the cath lab. I think that the easiest would probably to increase the capacity to do them in OR6. As you know, if we don't get a patient on the table by 2:30, the cases get canceled. So there is a lot of potential just to lengthen the day there and do 2 or 3 additional cases per day just by running a bit longer. So that's one point. You know, and I think that's a much easier than having to train out a whole entire new team in the new setting. The other point I wanted to make is about, you know, the reason why patients are admitted post TAVI, and often it has to do with pacemakers, right? So anything that you think could be a potential for in the picture of, you know, patients needing to have or, you know, having conduction disease after TAVI, and how we can optimize that on a more system level.
Our pacing rates dependent on valve. We do find that we have more with different platforms, but can be on average 8 to 10% of our cohort. And so with that, there is, for some of it's going to be very obvious. As soon as they've had the procedure, yeah, you need a pacer. Okay, let's go. It's very easy to fit those in. They work within our health system with kind of fitting them into the cath lab with cases very quickly. I think that's not the problem. The issues are the patients that then need kind of 24, 48 hours telemetry, ECGs, then an EP consult, and then we need to fit them in. There could be a potential working together with EP to streamline that and kind of have a little bit like a golden slot or a golden patient, so that if by a certain time, by a certain point, there is a patient that is identified at the post-TAVI from a Monday that may need a pacer, last thing on a Wednesday, that's the TAVI slot. Same thing potentially, although it's a little bit difficult with us operating on a Thursday, would be on a Friday or first thing on a Monday, just to try and minimize those, because we've had patients who have waited kind of 7 to 8 days due to the other pressures for the EP department to wait for a device. It's difficult because we're kind of then having to interact with their pressures and vice versa. You know, you could work it with something like that. My last center actually had interventionists that would pace, and they would do the pacer on the table, but then you're taking time off of the OR table from the next TAVI. So that's a win-lose, could be lose-lose situation. But I think there are definitely processes and ways of looking at it, and with mapping from the data that we have of how long on average do people wait, either to see EP and then to make a decision about pacer, and then to have one, that we could potentially streamline that. Absolutely.
Do you see the AI will help us to maybe understand those? I don't know if there are studies just to look at the big data and tell us that this patient requires longer admission, or just looking at an ECG, this guy probably needs a pacemaker, those kind of things.
We already know that patients are going in with the right bundle. Those patients are going to be a longer length of stay, and they're going to be higher risk of needing a pacer. We quote to them nearly potentially 15 to 20% needing a pacemaker, but they also get an IJ line rather than us taking the pacer out. So I think we can already highlight those ones that need to stay. And it all then comes down to implant. We can have patients that we feel that we have implanted perfectly, narrow QRS, sinus rhythm, not excited on the ECG going in, that I then had to put a pacemaker in because they go between left and right bundle. That I think is harder, but I think, especially with Pascal's expertise, it would be potentially feasible if we had a way of inputting all the data that we collected. Given the way that the Heart Institute tends to do its documentation, I think it's all extremely feasible. A lot of what we do is handwritten or hand typed into our notes. If we formalize this and put this into a data collecting and put it all together, I think it's absolutely feasible. But again, requires investment from the physician's point of view, time, but also then health system change of culture and way of working.
Just one last question. We have a very limited time, Pascal. You can just do your comment. Question is from Dr. Kwan Chan, and he asked maybe a short comment about prevention, if it's possible to prevent aortic stenosis. There's a trial.
I know very little about preventing it, I've got to say. I know that patients ask me all the time, can I take a tablet instead of doing anything else? I think it's worth looking into, but it's something I'm not too super familiar with.
Yeah, just to address very briefly the AI question, there's been a lot of research on this. I think despite having a lot of research being done, we're still early in the experience, just because of the availability of that data and finding the right predictors on what will, which patients are more likely to have a conduction disease or more likely to progress. There is some interesting work being done looking at anatomical features, like the actual position of the his bundle, the geometry of the membranous septum. So all those, I mean, there's some very interesting work being there. Again, very early, no prospective studies, all retrospective. So we're not quite there yet, unfortunately.